What if the pills sitting in your medicine cabinet right now are quietly damaging your heart? Every year, millions of Americans over 60 take medications they believe are keeping them healthy. But new research reveals a disturbing truth. Certain commonly prescribed pills may be linked to increased heart failure, stroke risk, and even shortened lifespan in older adults. A 2024 study analyzing over 2 million patients found that 5 specific medication types were associated with significantly higher cardiovascular risks in seniors. The most concerning part? Many doctors still prescribe these medications routinely, and most patients have no idea about the potential dangers. This video is for educational purposes only and is not medical advice. Always consult your healthcare professional before making any medication or lifestyle changes. Before we begin, tell us in the comments now your age and where you're watching us from. We're reading and replying to every single comment. Now, without any further ado, let's get started. Number 5, NSAIDs, the pain relievers that may strain your heart. Let's start with medications that millions of seniors use every single day without a second thought. Non-steroidal anti-inflammatory drugs, commonly known as NSAIDs, include over-the-counter pain relievers like ibuprofen and prescription medications such as diclofenac and naproxen. While these medications can be effective for managing arthritis, pain, and inflammation, research suggests they may carry significant cardiovascular risks for people over 60. A large 2016 study published in the British Medical Journal examined over 8 million patients across 4 European countries. The researchers found that current use of NSAIDs was associated with a 19% increased risk of hospital admission for heart failure compared to past use. But here's what really caught researchers' attention. The risk appeared to vary significantly depending on which specific NSAID was used and at what dose. Some medications in this class were linked to risk increases of 80% or more at higher doses. The concern isn't just about heart failure. Research published in the Archives of Internal Medicine found that among elderly patients taking diuretics for blood pressure or heart conditions, adding an NSAID into the mix was associated with approximately double the risk of hospitalization for congestive heart failure. The problem seems to be that NSAIDs may affect how the kidneys handle salt and water, potentially leading to fluid retention. They may also interfere with blood pressure medications, making them less effective. Consider Margaret, a 8-year-old retired nurse who had been managing her knee arthritis with daily ibuprofen for years. She took it religiously, believing it was safe because it was available over the counter. After developing unexplained swelling in her legs and increasing shortness of breath, she visited her doctor. Tests revealed early signs of heart failure. Her physician explained that the combination of her blood pressure medication and daily NSAID use might have contributed to her condition. After stopping the NSAID and working with a physical therapist on alternative pain management strategies, Margaret's symptoms improved significantly over the following months. The mechanism behind this association involves prostaglandins, substances in the body that help regulate blood flow to the kidneys and maintain the balance of salt and water. NSAIDs work by blocking the production of prostaglandins, which is how they reduce pain and inflammation. However, this same action may lead to decreased kidney function, sodium retention, and increased blood pressure, particularly problematic for older adults whose cardiovascular systems may already be under strain. Research from the American Heart Association suggests that the risks may be highest in the first few weeks of NSAID treatment and among those with existing heart conditions. A study in the Journal of the American Medical Association found that individuals with a history of heart disease who used NSAIDs had substantially elevated risks compared to those without such history. So what can you do if you rely on these medications for pain relief? First, have an honest conversation with your healthcare provider about your pain management needs. Alternative options might include acetaminophen for pain relief, which doesn't carry the same cardiovascular concerns. Physical therapy, targeted exercises, weight management, and topical pain relievers applied directly to the affected area may also provide relief without systemic effects. For some conditions, prescription medications from different classes might be more appropriate. The key is never to stop medications abruptly, but to work with your doctor to find the safest approach for your specific situation. Before we continue, if you've been enjoying the video so far, hit that like button so more seniors can see it and subscribe. We've got more powerful senior health tips videos coming every day, and you don't want to miss the next one. Number 4, proton pump inhibitors, the heartburn pills that may affect your heart. Moving to number 4, we're looking at one of the most commonly prescribed medication classes in America. Proton pump inhibitors, or PPIs, are medications used to reduce stomach acid production. Brand names include omeprazole, esomeprazole, lansoprazole, and pantoprazole. While these medications can be highly effective for treating conditions like acid reflux and ulcers, emerging research suggests that long-term use in older adults might be linked to cardiovascular concerns. A 2021 study published in Mayo Clinic Proceedings examined over 4,000 participants with an average age of 75 years. The research found that those with cumulative PPI exposure of more than 5 years had approximately double the risk of developing cardiovascular disease and heart failure compared to non-users. Even more concerning, a 2024 analysis published in Nature Communications, which included data from over 2 million participants, found that PPI use was associated with increased risk of ischemic heart disease, among other conditions. The relationship appears to be dose-dependent and duration-dependent. Short-term use for acute conditions may not carry the same concerns as long-term daily use that continues for years. Research published in the journal Circulation suggested that PPIs might affect the lining of blood vessels in ways that could contribute to cardiovascular problems over time. Take Robert, a 72-year-old retired accountant who had been taking a PPI daily for nearly 8 years after being diagnosed with acid reflux. He never questioned the prescription because his heartburn was well controlled. During a routine checkup, his new doctor asked about all his medications and their durations. After reviewing Robert's history and finding that he hadn't had significant reflux symptoms in over a year, the doctor suggested a careful tapering plan. They also discovered that Robert's late evening snacking habit might have been contributing to his original reflux issues more than any ongoing stomach acid problem. With dietary modifications and medication tapering, Robert successfully discontinued the PPI and maintained good symptom control. The proposed mechanisms behind this association are still being studied. Some research suggests that PPIs might affect the function of cells lining blood vessels, potentially leading to increased stiffness and reduced blood flow. Other studies have found that PPIs may interfere with the metabolism of certain substances involved in cardiovascular health. Additionally, PPIs might interact with antiplatelet medications, like clopidogrel, potentially reducing their effectiveness. A study in the European Heart Journal found that PPI users had a higher rate of cardiovascular events compared to those using a different class of acid-reducing medications called H2 blockers. Research from Stanford University suggested that the cardiovascular associations appeared to extend beyond any specific interaction with other medications, raising questions about the direct effects of PPIs on the cardiovascular system. It's important to note that PPIs serve important purposes and can be essential for certain conditions. The concern arises primarily with long-term use when they may no longer be necessary. According to research, many people continue taking PPIs long after their original condition has resolved, sometimes because they or their doctors simply forgot to reassess the need. If you've been taking a PPI for an extended period, consider scheduling a medication review with your healthcare provider. Ask whether the medication is still necessary and whether there might be alternative approaches. Lifestyle modifications for acid reflux might include eating smaller meals, avoiding late-night eating, elevating the head of your bed, and identifying trigger foods. For some people, a different class of acid-reducing medication might be appropriate. Never stop a PPI suddenly, as this can lead to rebound acid production. Any changes should be done gradually under medical supervision. Number 3, benzodiazepines, the anti-anxiety medications with serious risks. And number 3, we're addressing a class of medications that presents particularly complex challenges for older adults. Benzodiazepines are commonly prescribed for anxiety and sleep problems. They include medications like lorazepam, alprazolam, diazepam, and clonazepam. While these medications can provide short-term relief, research increasingly suggests they may be associated with serious risks in people over 60, including potential cardiovascular concerns. A 2020 study published in the journal Age and Aging analyzed data from a French nationwide cohort of nearly 55,000 individuals aged 65 and older. The research found that benzodiazepine use was associated with significantly increased risk of all-cause mortality. Even more concerning, the risks appeared highest with both short-term use and with chronic use that was discontinued, suggesting complex relationships that aren't fully understood. Research published in PLOS ONE, examining over 1.2 million participants, found that benzodiazepine initiators had higher rates of mortality compared to carefully matched non-users. A study focusing specifically on older adults after myocardial infarction found mixed but concerning results regarding cardiovascular outcomes. The American Geriatric Society has placed benzodiazepines on their Beers criteria list of potentially inappropriate medications for older adults, citing increased sensitivity and numerous risks. The cardiovascular concerns with benzodiazepines appear to be multifaceted. These medications have sedative effects that may worsen sleep-related breathing disorders, particularly concerning for those with heart conditions. Some research suggests they might affect heart rhythm and other cardiovascular functions through mechanisms that aren't completely clear. Additionally, the sedation and impaired coordination they cause significantly increase fall risk, and falls in older adults can lead to serious injuries that strain the cardiovascular system. Consider Dorothy, a 1-year-old former teacher who had been taking a benzodiazepine nightly for insomnia for over 3 years. She began noticing increased dizziness, occasional confusion, and what she described as feeling fuzzy-headed during the day. After a frightening fall in her bathroom that resulted in a hip fracture, her hospital care team carefully reviewed her medications. They recognized that the benzodiazepine might be contributing to her fall risk and cognitive changes. Working with her doctor, Dorothy underwent a very gradual tapering process over several months while learning alternative sleep strategies. She reported feeling more alert, steadier on her feet, and actually sleeping better with behavioral techniques than she had with medication. The mechanism of action for benzodiazepines involves enhancing the effect of a neurotransmitter called GABA in the brain, which creates a calming effect. However, older adults appear to be more sensitive to these medications, and their bodies may process them more slowly, leading to accumulation and prolonged effects. Research published in the Mayo Clinic proceedings noted that benzodiazepines increase risks of cognitive impairment, delirium, falls, fractures, and motor vehicle accidents in older adults. A study in BMC Geriatrics found that benzodiazepine prescriptions were associated with increased fall-related injuries within 30 days of prescription, with risk elevated by higher doses and concurrent use of other central nervous system active medications. The combination with certain other medications can be particularly problematic. Research has shown associations between benzodiazepine use and increased risk of pneumonia, emergency room visits, and hospitalizations in older populations. Major medical organizations strongly recommend against routine benzodiazepine use in older adults. The risks often outweigh the benefits, especially for conditions like generalized anxiety and chronic insomnia, where other treatments may be safer and more effective long-term. If you're currently taking a benzodiazepine, do not stop suddenly, as this can cause dangerous withdrawal symptoms, including seizures. Work with your healthcare provider on a careful, gradual tapering schedule. Alternative approaches for anxiety might include cognitive behavioral therapy, which research shows can be highly effective. For sleep problems, cognitive behavioral therapy for insomnia has strong evidence of effectiveness without medication risks. Other options might include addressing underlying sleep issues like sleep apnea, improving sleep hygiene, and treating any underlying depression or anxiety through safer approaches. Number 2, first-generation antihistamines and anticholinergic medications. Coming in at number 2 are medications with anticholinergic properties, including many first-generation antihistamines. These are drugs that block the action of acetylcholine, a neurotransmitter important for many body functions, including heart rate, muscle movement, and brain function. Common medications in this category include diphenhydramine, found in many over-the-counter sleep aids and allergy medications, as well as prescription drugs for overactive bladder, certain antidepressants, and medications for Parkinson's disease. A landmark 2019 study published in JAMA Internal Medicine examined nearly 285,000 people aged 55 and older. The research found that higher cumulative exposure to anticholinergic medications was associated with nearly a 50% increased risk of dementia compared to no use. The association appeared with total exposure of more than 1,095 daily doses over about 3 years. The relationship was observed across multiple anticholinergic drug classes, including antidepressants, anti-Parkinson drugs, and bladder medications. But the concerns extend beyond dementia risk. A 2021 study published in the Journal of General Internal Medicine followed over 19,000 initially healthy older adults and found that those with higher anticholinergic burden had a 58% increased risk of ischemic stroke compared to those with no exposure. The cardiovascular mechanisms aren't completely understood, but may involve effects on heart rate, blood vessel function, and other autonomic nervous system activities. Research published in Age and Aging, analyzing 26 studies with over 600,000 participants, found that any anticholinergic use was associated with increased risk of dementia, with stronger associations for long-term use. Even short-term use of 90 days or more showed associations with cognitive decline. Think about Helen, a 9-year-old retired librarian who had been using an over-the-counter sleep aid containing diphenhydramine every night for 5 years. She also took a medication for overactive bladder. She began experiencing memory problems, frequently losing her train of thought mid-sentence and having difficulty remembering recent conversations. Her daughter noticed the changes and encouraged her to see a doctor. During a medication review, the physician calculated Helen's anticholinergic burden using a standardized scale and found it was quite high. Working together, they identified safer alternatives: a behavioral sleep program and lifestyle modifications for bladder concerns, plus a different medication with lower anticholinergic activity. Over the following months, Helen reported improvement in her memory and mental clarity. The concern with anticholinergic medications is that acetylcholine plays crucial roles throughout the body. In the brain, it's essential for memory and learning. In the cardiovascular system, it helps regulate heart rate and blood vessel function. Blocking this neurotransmitter can have widespread effects. Research suggests that cumulative anticholinergic exposure might contribute to brain changes similar to those seen in Alzheimer's disease. A meta-analysis examining anticholinergic drugs found associations with incident dementia, with effects appearing stronger for longer-term use and higher doses. The medications most strongly associated with increased risks were certain antidepressants, anti-Parkinson drugs, and bladder antimuscarinics. Studies using brain imaging have shown that people with higher anticholinergic exposure may have reduced brain volume in areas important for memory. Research from the University of Washington found that the increased dementia risk associated with anticholinergic medications persisted even 20 years after exposure. The challenge is that many of these medications are available over the counter, and people may not realize they have anticholinergic properties. That nighttime allergy pill or PM pain reliever might contain diphenhydramine. Multiple medications with mild anticholinergic effects can add up to a significant burden. If you're taking medications with anticholinergic properties, schedule a comprehensive medication review with your healthcare provider or pharmacist. They can calculate your total anticholinergic burden and identify alternatives. For allergies, newer generation antihistamines like cetirizine or loratadine have minimal anticholinergic effects. For sleep, behavioral strategies and proper sleep hygiene are often more effective and certainly safer than medications. For overactive bladder, pelvic floor exercises and bladder training may help. And if medication is needed, some newer options have fewer anticholinergic effects. For depression, SSRIs generally have lower anticholinergic activity than older tricyclic antidepressants. Number 1, excessive polypharmacy and drug interactions. And now we've reached number 1. And this one might surprise you because it's not about a single medication. It's about taking too many medications at once, a condition called polypharmacy. Research consistently shows that older adults taking multiple medications face dramatically increased risks of cardiovascular events, falls, cognitive problems, and shortened lifespan, often due to complex interactions between drugs that can affect the heart and other vital organs. A groundbreaking 2020 study published in Circulation Heart Failure found that the vast majority of older adults with heart failure took at least 5 medications, and many took far more. The research showed that multiple medications were associated with increased risks of adverse drug events, hospitalizations, and mortality. What's particularly concerning is that many of these medications might interact with each other in ways that strain the cardiovascular system. Research published in the Journal of the American College of Cardiology highlighted that older adults with cardiovascular disease often have multiple other health conditions requiring treatment. However, taking medications for each condition without considering the overall burden and potential interactions can lead to a cascade of problems. The study noted that medication-related harm in older adults often arises from drug interactions and cumulative effects that weren't anticipated. A large 2024 analysis of medication use patterns found that anticholinergic medications, benzodiazepines, NSAIDs, and proton pump inhibitors were all commonly prescribed together in older adults, despite known concerns about each individual class and potential for interaction. The cumulative effect of multiple medications affecting the heart, kidneys, brain, and other systems can be far greater than any single drug alone. Consider Thomas, a 74-year-old retired engineer who is taking 14 different medications daily for various conditions, including high blood pressure, diabetes, arthritis, acid reflux, insomnia, and seasonal allergies. He felt increasingly tired, confused, and unsteady. When a geriatrician conducted a comprehensive medication review, she found multiple problematic issues. His blood pressure medication combined with his arthritis medication was affecting his kidney function. His sleep medication and allergy pill both had anticholinergic effects that were causing cognitive problems. His acid reflux medication might be interacting with his antiplatelet drug. Working over several months, the geriatrician carefully reduced his medication list to 7 drugs, choosing options with fewer interactions and eliminating medications that were no longer necessary. Thomas reported feeling like a fog had lifted. His energy improved, his mind felt clearer, and his balance was better. The problem with polypharmacy is that it increases exponentially, not linearly. Taking 2 medications might have 1 potential interaction. Taking 5 medications creates dozens of potential interactions. Taking 10 or more creates hundreds of possibilities, many of which haven't even been studied in older adults. Research shows that most drug trials don't adequately represent the older population, with multiple health conditions taking multiple medications. A study examining deprescribing in older adults with cardiovascular disease noted that many medications continue indefinitely without regular reassessment of whether they're still needed. Treatment goals that made sense at age 60 might not make sense at age 80. Aggressive treatment of borderline cholesterol or blood pressure in someone with limited life expectancy and multiple health conditions might cause more harm than benefit. The solution requires a paradigm shift in how we think about medications in older adults. Rather than adding a new pill for every symptom, the question should be whether each medication is truly necessary and whether the combined burden is optimal. This requires regular, comprehensive medication reviews, ideally with a physician trained in geriatric care or a clinical pharmacist specializing in older adults. Ask your healthcare provider these key questions. Is each medication still necessary? What is it treating? Are there non-drug alternatives? Are there safer medications with fewer side effects? What are the risks of continuing versus stopping each medication? Could any of my medications be causing my symptoms rather than treating them? Some medications can and should be stopped or reduced, but this must be done carefully under medical supervision. Some drugs require gradual tapering to avoid withdrawal effects. The process of thoughtful medication reduction, called deprescribing, is gaining recognition as an important aspect of quality care for older adults. Research shows that patients who undergo careful, systematic medication reduction often feel better, think more clearly, have fewer falls, and actually live longer than those who continue taking unnecessary medications. The goal isn't to avoid all medications, many are truly beneficial and life-saving, but to ensure that each one serves a clear purpose and that the overall medication burden is optimized rather than simply accumulated. So there you have it, 5 medication-related issues that may slowly affect your heart and overall health if you're over 60. From NSAIDs that might increase heart failure risk, to proton pump inhibitors that may be associated with cardiovascular concerns, to benzodiazepines with their multiple risks, to anticholinergic medications linked to dementia and stroke, and finally, to the overall burden of too many medications taken together without proper oversight. The message isn't to fear medications or to stop taking anything your doctor has prescribed. Medications save lives and improve quality of life every single day. The message is to be an informed, active participant in your own healthcare. Question every medication. Understand what it's for and whether it's still needed. Be aware of potential risks. Explore alternatives. And most importantly, insist on regular comprehensive medication reviews with your healthcare team. Remember that after age 60, your body processes medications differently than it did when you were younger. Your kidneys and liver might not clear drugs as efficiently. You might be more sensitive to side effects. You might be more vulnerable to interactions. This doesn't mean you can't take medications. It means you need thoughtful, careful management tailored to your age and health status. Work with healthcare providers who understand geriatric care and who take time to consider your individual situation, not just your diagnosis. Look for doctors who ask about your goals, your quality of life, and what matters most to you. The right approach balances treating conditions effectively while minimizing unnecessary medication burden. Age is not a disease. Growing older doesn't mean you have to accept declining function and health, but it does mean being smart about how you manage your health, including being thoughtful about medications. Your heart and your body will thank you. Now, we want to hear from you. Are you currently taking any of the medications discussed in this video? Have you ever experienced side effects that might have been related to medication interactions? What's been your experience with talking to your doctor about reducing medications? Share your thoughts and experiences in the comments below. We'd love to hear them. Thanks for watching. And remember, always consult your healthcare professional before making any changes to your medications.